The following podcast is part of a certified educational activity titled The Good, the Bad, and the GVHD, Leveraging Modern Therapeutics to Improve Post-Transplant Outcomes. Access the entire activity and complete the post-test at peerview.com/XRT860. Downloadable slides and practice aids are also available.
All right. Good morning, everybody. I want to thank everyone for joining us this morning. I know we've all been in Hawaii now for a few days, so the jet lag may start to be wearing off, but we appreciate everybody making the effort to be here early for this morning's session entitled The Good, the Bad, and the GVHD, Leveraging Modern Therapeutics to Improve Post-Transplant Outcomes. My name is Zach DePhillip, and I'm from Massachusetts General Hospital. And I'm honored to be joined this morning by my friend and colleague, Dr. Betty Hamilton from the Cleveland Clinic. I believe this is here. So the goals for today, we want to see what we can do to help increase knowledge about guidelines and evidence supporting modern therapeutics in the management of GVHD. We're hoping to equip everyone with skills they need to develop management plans for patients after transplant who develop GVHD or are starting to develop steroid refractory disease. And we also want to address any practical dosing or safety considerations with these current therapeutics. So as a lead-in, I'm just going to provide some general intro and background. So graft-versus-host disease is the main immunologic complication after hematopoietic cell transplantation, and it comes in two distinct forms. You have the acute GVHD and chronic GVHD. These are not defined by time, but generally, acute GVHD does occur in the earlier months after transplant and classically involves either the skin, the GI tract, or the liver. You would maybe call a first episode of acute GVHD classical GVHD or de novo acute GVHD, and then you may have subsequent episodes being characterized as either, excuse me, recurrent episodes, persistence, or late acute if it happening later on after the transplant. Chronic GVHD typically happens later on after transplant and can involve a number of organs as listed here. The most common are the skin, the mouth, and the eyes. Again, you can have classic chronic GVHD with no ongoing or acute GVHD, but if you have a situation where maybe a patient has acute and then it kind of morphs into a chronic situation, or you have features of both at the same time, this is sometimes referred to as overlap. We're not going to emphasize prophylaxis too much in this symposium just because it's such a broad topic on its own, but we can't really talk about GVHD without talking about some of the advances in GVHD prophylaxis. So any patient who undergoes a transplant needs a GVHD prophylaxis approach. We'll start in the reduced intensity setting, where most patients at this point, at least in the US, I think are using post-transplant cyclophosphamide as their GVHD regimen of choice. This is definitely the use of PT-Cy. We are also has dominated the haploidentical scene for quite some time now and is also very frequently used in mismatched unrelated donors. But there are some other options. There are some graft manipulation approaches that some centers prefer, and it's definitely in outside of the US and Europe, ATG is still commonly used. In the myeloablative setting, I think if you talk to colleagues at different centers, I think you can see a lot more variance in what people are using for their GVHD prophylaxis. You need to consider if it's a full HLA match or maybe a 7 out of 8 mismatch. I think there is still increasing use of PT-Cy in these settings, though some centers still prefer CNI-based approaches, either alone or in combination with abatacept, and there's other approaches as well. I just highlight here, there was a recent GVHD guidelines from the EBMT, and our European colleagues were advocating for the use of either ATG or PT-Cy in the setting of a matched unrelated donor transplant or mismatched unrelated donor transplant, but their recommendation in the matched sibling situation was still to use ATG over PT-Cy. So moving on to what happens when a patient develops acute GVHD. So this is for acute GVHD. if you have a patient who develops grade 2 to 4 disease, which is typically symptoms that probably require treatment, you may initially consider some adjustments in their baseline immunosuppression, but otherwise, they are likely going to need systemic treatment. And in that situation, we are still typically using steroids as our first line treatment. Um, uh, the dose that we use really kind of depends on the organs involved and their severity. If they just have limited upper GI disease, you may be able to get away with lower doses of steroids. But for patients with more advanced disease, especially that in the lower GI tract, we're usually using higher doses as high as 2 milligrams per kilogram per day. You'll then evaluate the patient's response. If they're responding, that's fantastic, and you'll try to taper the steroids and see how that goes. If you're not having a response, or what I might say is an inadequate response, you're probably going to be compelled to use a next line agent. A lot of these same principles apply in chronic GVHD, though I will say that with the nature of chronic GVHD, sometimes the onset of symptoms is a little more gradual, and you may be able to be in a position where you can initiate topical therapies alone before you kind of need systemic therapy. But again, when we get to needing systemic therapy, the current standard is to use steroids, typically somewhere in the 0.5 to 1 milligram per kilogram per day dosing. And again, we will look to see if the patient's responding. I will say that in chronic GVHD, as we'll talk about later, I worry about patients really being able to get a sustained response to steroids. So again, if there's no response or inadequate response, additional therapies will be needed. So what can it look like after you give steroids? So we'll start, I guess, over on the left. This is what we would all be hoping for. You get a patient who you give steroids to. They get clear, sustained improvement. There's no flares. Everything's going well. If this is what we frequently encountered, we wouldn't have much to talk about this morning. So the more likely scenarios are the other two, which is maybe you have a patient who has some initial response, but then they start to have recurrent disease after that, or maybe a patient who doesn't respond at all, and these are patients who will need additional therapies. The good thing is that over the last decade or so, we've had a number of approvals in GVHD management for different therapeutics that have expanded our treatment algorithm and our treatment options. So if you're thinking initially about chronic GVHD with ibrutinib, that was FDA approved in 2017. And then we've had the addition of ruxolitinib and belumosudil in 2021, as well as axatilimab in 2024. In steroid refractory acute GVHD, we have ruxolitinib in 2019, and then most recently, remestemcel-L in pediatric steroid refractory acute GVHD this past December. Abatacept is a GVHD prophylaxis medication for acute GVHD prophylaxis that was approved. And then also used in the US for a long time, ECP, I just want to highlight here, does have approvals in other countries outside the US. So with that, I'm going to turn it over to Betty to start our first case.
Thank you so much, Zach. All right. So I am going to now focus a little bit more on some of the challenges and updates for treating acute graft-versus-host disease. And to do this, we're going to go over a case, and we're going to have some discussion points that Zach and I will talk a little bit through. So this is a consult that we are hypothetically seeing. This is a patient with myelodysplastic syndrome who's undergoing an allogeneic transplant. So we have Brian here, who is our 64-year-old male. He's diagnosed with high-risk MDS with excess blasts, high-risk mutation in ASXL1. He presents with weight loss, shortness of breath, fatigue, bruising. He does have a medical history of coronary artery disease. He had a couple stents placed a couple years ago. However, overall, he's well compensated. He has a good functional status. So he's treated with azacitidine. A donor search is initiated, and he's found to have an 8 out of 8 HLA matched unrelated donor. He subsequently undergoes a reduced intensity peripheral blood stem cell transplant, and his GVHD prophylaxis is post-transplant Cytoxan, tacrolimus, and MMF. So our first point of discussion, and as Zach mentioned, although really the focus of this presentation this morning is more on treatment, I think it's important to sort of touch on prophylaxis a little bit. And so was PT-Cy the optimal prophylactic choice in this setting? And I think yes. So as Zach had mentioned, we now have data from BMT-CTN 1703, which is a phase 3 randomized study comparing post-transplant Cy, tacrolimus, MMF, compared to tacrolimus and methotrexate in reduced intensity peripheral blood stem cell transplants. And what that trial showed is that post-transplant Cy was associated with a significantly higher 1-year GVHD-free, relapse-free survival. And post-transplant Cy thus has become a new standard of care in the reduced intensity setting. I think it's also important to note, and sort of why we kind of threw in that this patient may have a history of coronary artery disease and a cardiac history. There often is concern in our field about using post-transplant Cy and its impact on cardiac toxicities and complications. So some I've heard, colleagues in the field dose reduce post-transplant Cy or would avoid post-transplant Cy in this setting. I personally do not. I would say, especially for a patient who has a well-controlled disease, that post-transplant would still be the standard of care, and that some of the data with cardiac toxicities can be conflicting. I'm going to ask Zach if he has any other opinions or anything to add.
No, I would agree. I would use PT-Cy in this patient based on the CTN data. And as Betty said, we don't have that much information, at least in this prompt, about the degree of the coronary disease. But with the information given, I would still proceed with PT-Cy.
Great. All right. So we're going to move on with Brian. He successfully undergoes his infusion of stem cells. However, unfortunately, around day 35, he develops a macular papular erythematous skin rash that encompasses about 30% of his body surface area. And even more unfortunately, he develops large volume watery diarrhea, more than 7 bowel movements a day, and the volume is approximately over a liter and a half. So he undergoes an endoscopy to try to figure out what this might be. The biopsy does not show any evidence of any infectious sources, nor does any other infectious workup. However, the biopsy changes show, crypt loss, apoptotic bodies, and so this is highly suggestive of acute graft-versus-host disease. And his clinical team plans to initiate methylprednisolone at 2 milligrams per kilogram per day. So a couple discussion points to go over is this high-risk disease, and is 2 milligrams per kilogram per day an appropriate starting dose for this patient. So we know since this patient has developed a rash that's about 30% of his body surface area, that makes him have stage 2 skin, and he has diarrhea that's over a liter and a half, which makes him have stage 3 GI and an overall grade 3 acute graft-versus-host disease. We also know by our Minnesota Clinical Risk Scoring System is largely driven by lower GI GVHD, and this patient meets criteria for high-risk disease. This does, as Zach kind of briefly went over in his overview, this patient is someone who would warrant high-dose steroids. This is our standard first-line treatment of 2 milligrams per kilogram per day of methylprednisolone or corticosteroid equivalent. And I believe this would be an appropriate starting dose for this patient. Any other comments or thoughts to add, Zach?
Not too much. I would say that, you know, in our practice, since we've been using more PT-Psi, I don't think we've seen as much severe acute GVHD. So with a presentation like this, we would definitely want to make sure we're ruling out other etiologies to really kind of make sure that we feel secure on that GVHD diagnosis. Um, I would say that I think that the clinical signs that we're seeing here will probably lead you down the correct path. One thing that comes up sometimes is GVHD blood-based biomarkers and how they might be able to help further provide some additional information. The general concept with the biomarkers is that they may be a little more accurate than what we see clinically, although usually they kind of correlate with what we're seeing. So we don't have information about that here. But my guess is that if we did get them, they would likely correlate with high-risk disease.
Those are excellent points and something that we'll also touch on in some of the subsequent slides. All right, so moving on with our case. So this patient, Brian, is diagnosed with grade 3 acute graft-versus-host disease. He started on 2 milligrams per kilogram per day of methylprednisolone. After a little over a week of treatment, although he might have a little bit of mild improvement, he really still has significant lower GI GVHD symptoms of over a liter of diarrhea per day and still has a little bit of a skin rash. So a couple discussion points here. Is this patient clearly steroid refractory? What would be the most appropriate second line of treatment for this patient with steroid refractory acute GVHD? And are we eager to start something even earlier than a week? And what are some other considerations, particularly regarding dosing and safety, as well as the need to consider other issues like healing of tissues? So first, let's tackle whether this patient is steroid refractory. So we know that there have been many definitions of steroid refractory that have been proposed. And generally, the consensus is that steroid refractory is defined by either progression of acute GVHD after 3 days of appropriate first-line treatment, which is high-dose steroids, no response after 7 days, or an inability to taper the steroids beyond or less than 0.5 milligrams per kilogram. So this patient still has grade 3 acute GVHD. Although some minimal improvement, he still really has high-risk disease, and I would call him steroid refractory. And as we'll go over in a little bit in the subsequent slides, we now have an FDA-approved agent of ruxolitinib as a first-line treatment for steroid refractory acute GVHD. It is important to acknowledge sort of clinically and real-world practice. It oftentimes can be very difficult to sort of sit on these patients. They're sick, they have lots of complications, they're having large volume losses, they can have infectious complications. And oftentimes we are at least thinking about and considering starting some second-line therapy sort of earlier in the course, especially for a patient like this who's sort of clearly high risk. It's important, again, as I mentioned, these patients tend to be quite ill. They can be cytopenic. This patient's is still less than 100 days post-transplant. It's very likely that not only in terms of his time course, but sort of the impact of GVHD, he could be quite cytopenic. So when we're using an agent like ruxolitinib, again, which we'll go into, it's important to consider sort of the side effect profile if this patient is getting more cytopenic. And sort of his infectious risks. Again, this patient also, it's critically important to think about optimizing all supportive care measures. Again, good infectious prophylaxis, nutrition as able, bowel rest, all of these things. And there's a lot of emerging data now that we know that GVHD is not only about inflammation, allergic reactivity, but also the healing of tissues. So sometimes patients are having continued diarrhea, not just because of an inflammatory response, just because the tissues are damaged from infection, cytotoxic therapy, and the GVHD itself. We're going to touch on some of this in the subsequent slides. Just briefly, Zach, anything else to add to this?
Mm, I would just say that, there's a question here, would we start second line therapy any earlier than 8 days into treatment, like in this situation? And as Betty said, I think it's sometimes hard to sit and wait on these patients. I think, a consideration is how severe, their presentation is, I guess, at the onset. So, with a patient who has higher volume diarrhea and lower GI involvement, I think it's harder. I think it's going to be a longer course to recovery. I think it's harder to wait. If you flip the situation, for example, and we're dealing with skin only disease, that's something probably being treated as an outpatient. I probably have a little more leeway to say, let's see how things go, and if it's maybe just taking a little longer to respond before initiating a second line therapy.
Right. Okay, so what systemic agents do we have? So this table is largely from the NCCN clinical practice guidelines. We now, as I mentioned, have ruxolitinib that's FDA approved for steroid refractory acute GVHD, making this a Category 1 recommendation. This was supported by data from the REACH-2 trial, which is a randomized uh, prospective trial comparing ruxolitinib versus best available therapy, which showed significantly improved day 28 responses of over 60% compared to about 39% in best available therapy, making this really sort of the standard for steroid refractory acute GVHD. You can see that there's a variety of other agents listed here that have been studied in this setting with some efficacy. Some of these agents often tend to target specific organs a little bit better than others. For example, vedolizumab and lower GI GVHD. Zach also briefly had mentioned in his overview that EBMT recently published some guidelines regarding the treatment and prevention of graft-versus-host disease, and this largely reflects the NCCN recommendations as well, including the Category 1 recommendation for ruxolitinib. After ruxolitinib, again, there are many agents that potentially can be used. There's not really any current guidelines that tell us which agent to choose over the other. And we often make this clinical decision based on target organs, toxicities, and the like. So we now have two FDA treatments for steroid refractory acute GVHD. As mentioned, we have ruxolitinib, which is actually FDA approved for both acute and chronic. Of important note, the starting doses for ruxolitinib in these two different settings are different. For acute GVHD, it's 5 milligrams twice a day, which can be increased if the patient is tolerating adequately. And then chronic, which Zach will go over a little bit more, is 10 milligrams twice daily. We also recently got FDA approval of remestemcel-L in the pediatric population. And also, just to mention, ruxolitinib's for patients who are 12 years and older. But remestemcel was FDA approved in the pediatric setting, which we'll go over a little bit of that data. So I just wanted to also point out, although it's great, of course, that we've seen a lot of progress in the last decade over treatments and approvals for the treatment of steroid refractory GVHD, there's still work to do because ruxolitinib does have some limitations. So even though it had an overall response rate of over 60%, durable overall responses were only about 40%. We still sort of lack definitions for defining what being refractory to Rux means, how long one stays on treatment, and when do we call someone refractory to ruxolitinib. We also have data that actually was an analysis and publication presented by Zach that showed that use of biomarkers actually showed that the magic algorithm probabilities or MAP, so low risk by biomarker, did show those patients benefited from ruxolitinib. However, patients who had a high MAP or biomarker high risk patients actually did not have the benefit of ruxolitinib. So even though low MAP, less severe GVHD, and the use of ruxolitinib were all associated with day 28 responses, patients with high biomarkers or high risk biomarkers, high MAP, still had significantly high non-relapse mortality, regardless of the use of ruxolitinib. So I think there's still some work to do. So remestemcel, just briefly, this is human bone marrow-derived mesenchymal stem cells from healthy adult volunteer donors. This was evaluated in a phase 3 prospective multicenter study in 54 children with steroid-refractory acute graft-versus-host disease. Remestemcel was given for 8 doses over 4 weeks. If patients had a PR or mixed response, they were allowed to continue remestemcel for 4 doses over 4 weeks. And this product showed that there was significantly improved day 28 overall response rates compared to a pre-specified control value of 45%. And the overall response was 70%, which was sustained through day 100. As well, CR rates also improved at day 100 from about 30% to 44%. And there was good overall survival at 74% at day 100. So remestemcel was well tolerated. There was not any safety concerns, and thus this led to the FDA approval just recently in December of 2024 for pediatric patients over the age of 2 months. So as I sort of mentioned a couple slides ago, we still have work to do. Ruxolitinib is great, but there's still room for improvement. So what else is new out there? So we now know there's a lot of data to support that the intestinal microbiome undergoes significant changes through the transplant process. And in particular, there's a significant loss of microbial diversity, which is highly associated with graft-versus-host disease. We know that microbiota fecal transplants have been well studied in recurrent refractory C. diff and is a sort of an established standard of care, and has shown good safety and efficacy. And several pilot trials have also now studied this in graft-versus-host disease. And taking this all together, this led to this phase 2 trial that was assessing the safety and efficacy of first-in-human pooled allo-fecal microbiota with a product called MAT-013 in the treatment of steroid-refractory acute GVHD, and led to some promising results in a heavily pretreated population with overall response rates of 38% and relatively favorable safety. Some other new developments to touch on is this concept, as I had mentioned before in the case, of the healing of tissues. So we also know that there's sort of hormonal influences that really help with regeneration and survival and growth of the intestinal stem cells and PANS cells that get damaged by cytotoxic chemotherapy and the impact of graft-versus-host disease. And preclinical models have demonstrated that GLP-2 is one of these hormones that is associated with graft-versus-host disease. And there have been some studies that have showed that GLP-2 agonists in preclinical models can help stimulate intestinal stem cell survival and growth, as well as PANS cell survival and growth, which these cells obviously are lost in severe acute GVHD, GI GVHD. So this was recently presented, the Stargaze trial, which was the first prospective trial of a GLP-2 analog in steroid-refractory lower GI GVHD. This GLP-2 analog, apraglutide, was added to ruxolitinib in steroid-refractory GI GVHD. It had a good safety profile and led to overall response rates of 58%. Including several CRs. And just going to touch lastly on this, on alpha-1 antitrypsin, also as a promising therapy for both steroid-refractory and upfront high-risk graft-versus-host disease. So AAT is a naturally occurring serine protease and agent and has been shown to induce responses in steroid-refractory acute GVHD, as shown it on the left. And I just want to highlight and call attention to a late-breaking abstract that will be presented tomorrow afternoon, a trial from the BMT-CTN, which was a randomized double-blind placebo-controlled trial of alpha-1 antitrypsin in high-risk acute GVHD that has shown pretty promising and exciting results. So just in summary, this can be seen as an algorithm for steroid refractory acute GVHD. Obviously, this is still a really bad disease, so if we have a clinical trial, this is always the right answer. But we now have ruxolitinib as a sort of standard treatment for steroid refractory acute GVHD. There's still questions about how long to do it and what constitutes ruxolitinib refractory. Important to consider some of these other agents. Other considerations like toxicities and organ involvement, and then obviously optimizing supportive care. And with that, I'm going to turn it back over to Zach to talk about chronic GVHD.
All right, thank you, Betty. So we're going to move on to a second case. This is a 60-year-old woman named Susan who has a diagnosis of myelofibrosis. So she's diagnosed with high-risk myelofibrosis. She has splenomegaly and constitutional symptoms. She receives JAK inhibitor therapy for her splenomegaly and then proceeds to an allogeneic transplant. For her transplant, she receives a reduced intensity haploidentical transplant with post-transplant cyclophosphamide as her GVHD prophylaxis. She's now 14 months after her transplant and is doing quite well from a disease perspective, and then starts to develop a number of symptoms. She's feeling a little bit more short of breath. She has a rash, and she's also reporting the onset of both oral and ocular dryness. So the first question here is, does the timing of these symptoms align with a likely case of chronic GVHD? And then the second question here is, how quickly would we move to initiate steroid therapy? So I would say that this seems to be fitting what we would expect to see clinically as a constellation of chronic GVHD symptoms. As we mentioned earlier, the skin, the eyes, and the mouth are some of the most common organs to be involved. It's the right type of timing. The shortness of breath, you start to think a little bit like, could this patient have some lung involvement? They could, but at this point, the shortness of breath alone is probably still a little bit vague. You would probably want to get pulmonary function tests to kind of further confirm that. But I would probably be apt to think of this patient as a chronic GVHD patient. Depending on what the symptoms were like at the start, I probably would try to use some topical therapies in the mouth, maybe a dexamethasone swish and spit. You could maybe use some topical steroids on the rash, depending on its characteristics. But in this kind of scenario where you have multiple organs that are involved, I'm probably leaning more towards initiating systemic therapy with steroids probably sooner than later. Betty, I don't know if you have some additional thoughts.
Yeah, I completely agree with you. I think, obviously, chronic GVHD is very heterogeneous. It can affect multiple organs. There can be a lot of other concurrent things going on. Obviously, when you see this patient on exam, there are other findings that can help you lead to the diagnosis, like lichenoid changes. We also, tend to, at our center, work closely with our ophthalmologists and our pulmonologists to help sort of distinguish other potential etiologies. But assuming this patient has multi-organ involvement, while optimizing topical therapies, I would start systemic therapy.
So that's what's happened. We're going to say that this patient has chronic GVHD, and we start prednisone at 1 milligram per kilogram per day. So after 2 weeks of treatment, the shortness of breath and the ocular symptoms are basically unchanged, though they have had a little bit of improvement in the rash and the oral dryness. So the questions at this point in the case are, how would we manage the prednisone dose and consider switching to another agent, and what maybe would be that subsequent sequence of therapies? So in chronic GVHD, I think we know that for patients who end up going on systemic therapy, Many of them are going to need multiple lines of treatment. Um, with that in mind, I tended to give prednisone a relatively short leash before I would start a second therapy. I think one of the things we see with chronic GVHD treatment with steroids is that you can get like a transient, maybe a little more of a superficial improvement in these patients' symptoms, but they're rare, unlikely to be long lasting and deep responses just to steroids alone. So I typically within a month, I would say I'm already thinking about starting a next agent. Um, Based on the data and the FDA approvals, I typically reach for ruxolitinib as my first agent after steroids. And then I usually give that a little bit longer to see kind of what that response looks like.
I agree with you, Zach. I have a similar approach. I think what in this particular patient, what's concerning is sort of the persistent shortness of breath, and assuming that we think that this and getting pulmonary function testing and CT scans, and that there's sort of obstructive pattern. And I'm a little bit more aggressive with lung GVHD. We'd also use therapies like FAM or the fluticasone, azithromycin, and montelukast if we have a high suspicion for lung GVHD.
So in this case, ruxolitinib is started, and there's continued improvement in this patient, most of the patient's symptoms over the next few months. But around 3 months into treatment, the symptoms seem to relatively plateau. So the question is, what would be the next step in therapy? And then specifically regarding whether the next choice would potentially be belumosudil or axatilimab, like kind of what would we do as a next step? So, you know, I said I would usually give prednisone a shorter leash. I usually consider giving the FDA approved agents a little bit of a longer leash, so to speak. So I don't know if just after 3 months I would necessarily look to switch or add therapies. I might give it a little bit longer. I think one thing that's come out from some of the data that we've published on and some of the things that have been presented at this meeting is that some of the organ manifestations take longer to respond. So as Betty said, if we do think this patient really has lung involvement, that's usually something that takes an additional number of months to really see an improvement in. And if everything else is doing well, I might just kind of hold. If not, I think either Bella. I know that's not the great answer everyone's looking for, but really, I do think belumosudil or axatilimab are both good options here. We'll talk about their mechanisms of action. They both have data to support that they can address fibrosis, and they both have data to support that they can be effective in fibrotic manifestations. So I do think both options are there, and there's no head-to-head data to really help us choose one over other at this point.
Yeah, I completely agree. I think this is probably the most common question we get, when to use what therapy, what sequence, what's next, and we just really don't have the data for that. So we do rely on, you know, organ-specific considerations, toxicity, access. These are all important things to consider as well.
So these are agents in the NCCN guidelines for treatment of chronic GVHD. The ones that we have highlighted here are the ones with FDA approvals. So you have ruxolitinib as a Category 1 recommendation, again, supported by the phase 3 randomized REACH-3 trial. And then we've had recent FDA approvals with axatilimab, belumosudil, and ibrutinib as well. It's important to know here, right, that often, as we know from our clinical practice, these agents are given in conjunction with some of the original immunosuppressive agents they may have been on. So if they're still on tacrolimus when they develop GVHD, a lot of times we keep that going. Sometimes people will restart that. A lot of times people are also receiving steroids. And one thing that has become common practice, at least here in the US, is sometimes to layer these therapies over time. So if a patient's already on ruxolitinib, instead of stopping ruxolitinib to add belumosudil, do you just give both of them at the same time? Um, these are dosing considerations, so just kind of knowing what the doses are for these medications. This is in alphabetical order. So axatilimab, the FDA approved dose is 0.3 milligrams per kilogram by IV every 2 weeks in adults. and as well as pediatric patients who weigh at least 40 kilo. In belumosudil, the approved dose is 200 milligrams once a day, though there are dose adjustments for patients who are on PPIs. Ibrutinib, for patients who are at least 12 years old, it's 420 milligrams a day, with potentially a little bit of a lower dosing in the younger pediatric patients. And here, just pointing out that in a chronic GVHD, the starting dose for ruxolitinib is 10 twice a day rather than the 5 twice a day that was approved in acute. So over the last year, what are some updates that have maybe come out on data from on these agents? So we'll start with updated 3-year follow-up for the patients who were treated on REACH3. Again, this is the registrational trial for ruxolitinib in second-line treatment of chronic GVHD, where patients were randomized to receive treatment with ruxolitinib or a choice of best available therapies. And in that trial, ruxolitinib outperformed the best available therapies in terms of response rates and durable responses as well. What we see here is that in 3-year follow-up, the response seems to be long-lasting, right? So this is failure-free survival. This is a composite survival endpoint that says, is the patient alive without relapse of their underlying disease, and have they not needed a change to a next GVHD agent? And you can see that this is something that continues to be much higher for the patients who were receiving ruxolitinib as compared to best available therapies. So it seems they're getting long-lasting responses from being on ruxolitinib early on in their course. We also have recently published 3-year follow-up on the patients from the Rockstar study. So this was the registrational trial for belumosudil. This was a randomized phase 2 trial for patients who had failed multiple lines of therapy for their chronic GVHD, who were randomized to receive one of 2 doses of belumosudil, either once a day or twice a day dosing. What we saw is that the 3-year overall response rates were approximately 75%, regardless of the dose. And again, looking here at failure-free survival, if you're looking at the total population or specifically in patients who are identified as responders, we are seeing kind of, again, long-lasting durable responses in these participants, I think, which is very encouraging for the chronicity of chronic GVHD and what we see typically in clinic. So newest to the market now is axatilimab. So it's a monoclonal antibody that targets the CSF1 receptor. This is a target that's important. It is present on monocytes and macrophages, and it can contribute to both inflammation and fibrosis. And therefore, it makes sense to target this pathway. Agave 201 was a large randomized trial that looked at 3 different doses of axatilimab. Again, and these were in patients who had chronic GVHD that had failed multiple lines of therapy. What you can see here were the overall response rates for all 3 doses. Interestingly, right, all 3 doses met the primary endpoint for response that was dictated in the protocol. But interestingly, it is actually the lowest dose, the 0.3 milligram per kilogram every 2-week dose, that had the overall highest response rates. And generally, these responses tended to occur quickly, with a median time to first response at about somewhere between 1 to 2 months. You may ask the question, is there a group of patients that seems to benefit from axatilimab maybe more based on their basic characteristics of their disease, or vice versa, is maybe there a group of patients that seems to not respond? And it seems that across a number of important subgroups, axatilimab seems to maintain its efficacy. So whether you're looking at the age of the patient, the number of lines of therapy they've been on, or the specific therapies they've been on before, if you're looking at their GVHD severity, or if you're looking at the organs involved at baseline, the number of organs, it seems to maintain its efficacy. These were the organ-specific response rates. So you can see here that axatilimab demonstrated efficacy across a number of different organs. I think importantly, fibrosis-dominated organs, whether you're looking at the joints and fascia, the lung, or the skin, I think there were encouraging response rates. As we note here, the skin overall response rate of 27%. It just should be noted that, and it's delineated in the manuscript, that there were a number of patients who had sclerotic skin. These are patients who have a more difficult time achieving a response according to NIH criteria that we use for these trials. But 66% of patients had improvement in their skin tightening symptoms, and 44% actually had reductions in their BSA that was involved by sclerosis. So I think that's a very encouraging sign. This was an interesting sub-analysis of the data that was presented at ASH that I just want to highlight real quickly because I think it addresses something that we run into in clinic, which is like, is my patient getting better? Are they not? Are they responding? And how maybe do the patient's symptoms correlate with what we're going to grade when it comes to the trials? So what this basically shows is that in a few of the organs, we're seeing that the patient's perception, their symptoms, they say they start feeling a little bit better before we actually see that response. So if you can see here, we have examples in the mouth, the lungs, the eyes, and the skin. The Lee symptom scale symptoms specific to that organ seem to respond a little earlier than what you actually are seeing when it comes to an NIH response criteria. So we mentioned briefly earlier that in our clinical practice, we are often giving more than one agent at the same time. We may, for example, be giving ruxolitinib and then add belumosudil or vice versa. And there's, emerging real world data on this practice. There's a number of abstracts that have been presented, typically in poster form over the last few years. But, and the question is, can we target multiple pathways maybe with a single agent, right? So this was a ASH abstract for rovadicitinib. It's a novel oral inhibitor of both JAK and ROCK. And this was 44 participants with steroid refractory dependent chronic GVHD. This is very promising swimmer's plot here, showing a 86% overall response rate in the first 6 months. And just noting here, these little triangles are first partial responses, and many of those responses are happening within the first month of treatment. So we have these approved agents, and we don't have really comparative data to help select. So what kind of things do we keep in mind when we're trying to make these decisions in clinic? One consideration is toxicities. I think a lot of people think about this when they're making their decisions. So if you have a patient who has pre-existing cytopenias, maybe you are a little more hesitant to use ruxolitinib. If a patient has cardiac issues, that's a consideration again for patients with ibrutinib, and just also acknowledging that you can see rise in liver function tests with both belumosudil and axatilimab. You can consider their underlying malignancy. I mean, it does theoretically make sense to give ibrutinib to a patient with a B-cell malignancy or ruxolitinib to a patient with myelofibrosis or JAK2 positive disease, though I'm not sure I really use that as a determining factor in my practice. We do have data on treating lung disease or advanced fibrosis with ruxolitinib, belumosudil, and axatilimab. These agents are available for patients who are pediatric, at least 12 to 18. The question mark here with axatilimab just is really about it's based on weight. And then just also acknowledging that all the agents are oral with the exception of axatilimab. And then finally, kind of where the big trials going forward. So they're really trying to take some of these agents that we talked about today and move them to the first line. So at your centers, you may be participating in these trials or hearing about them. These are 3 ongoing, relatively large trials looking at moving these agents into the front line. It makes a lot of sense. Can we treat chronic GVHD more effectively in the first line setting? Because does that maybe alter the disease course and trajectory by using effective agents early on? So there's a phase 3 trial looking at belumosudil versus placebo in combination with steroids in the first line. There's a trial that looks at a few different combinations. One is ruxolitinib alone. One is ruxolitinib with axatilimab, and those are without steroids. So that's a very novel and I think compelling concept. In newly diagnosed chronic GVHD, and there will also be a phase 3 trial of axatilimab or placebo in combination with steroids in chronic GVHD first line treatment as well. And I think that kind of ends the presentation, but we do have a few minutes here. I know we're running slightly late. For any questions or any questions, we'd be happy to answer. We can answer them at the podium or afterwards on the floor.
Zach, we had a few questions that were submitted during the talk. One is, do you have any advice for using dasatinib for steroid-resistant GVHD, or any experience in using the medication?
Which agent?
Dasatinib.
Um, I have not. I've not used dasatinib in chronic GVHD. Um, Again, that may be a consideration that might consider in a patient who's maybe Philly positive, and you might want to be using dasatinib anyway. But typically, my Philly positive patients are already on maintenance, maybe with dasatinib or another TKI. Um, but I've never used it specifically for chronic GVHD.
Yeah, I agree. There has been previous data with TKIs like imatinib and chronic GVHD, but with some of our other agents, I think they have better response rates and don't have much on dasatinib. Um, can you comment on Rux dosing with azole therapy, and is there a place for budesonide therapy in gut GVHD?
So, we adjust the ruxolitinib dose for concurrent use of fluconazole. Um, there is still a lot of questions about other azoles, but it seems a conversation comes up all the time, but my understanding, is that right now the recommendation is the adjustments only for fluconazole, and that's what we do. I have spoken with people at other centers who do adjust for other azoles. To me, I think it's a lot also about just monitoring the patient's cytopenias and their symptoms. Like you know, it, ultimately, if they're doing well on if they're doing okay, their counts are not dropping. I think you can kind of get away without the dose adjustment sometimes. But obviously, if you're starting to see counts drop, you can adjust the dose. And I usually find that by just adjusting ruxolitinib dosing, you can maintain them on treatment and have it still be efficacious.
Agree. And I also very commonly use budesonide in GVHD. And then maybe one last question, which is actually not really that quick, but comment on rate of taper of steroids for responding and not responding acute and chronic graft-versus-host disease, which I think personally, it's sort of, we don't really have data for this. It's very provider dependent. To me, it's also very patient dependent on their toxicities and response. I mean, if really someone is not responding and they're having toxicities, I taper them actually fairly quickly.
Yeah. When patients with chronic GVHD are on multiple agents, I think steroids is what I try to taper off first. I think having other agents on board as the clinician, it gives you just a little more, you feel like you have a little more of a safety net to get down on the steroids with maybe avoiding any type of flare. Um, I'm a little slower on my tapers of other medications if the patients are responding, but typically I try to get them off steroids as the first agent to go.
Um, Buddy in the audience with any questions? We had a couple that were submitted online too. And we might have a couple extra minutes. Do you combine any other therapy with Rux when treating steroid refractory acute?
Um, so I think one thing that's interesting that Betty kind of showed a little bit, but I maybe didn't use the exact wording, is just like in acute GVHD, I think some of the agents that we think about, I think about them being more organ specific, right? So I think, you know, if you're going to think about using like FMT, you're looking for a patient who has lower GI involvement. Um, so what we do sometimes at our institution, we will, for patients who have lower GI involvement, we will give vedolizumab as an additional agent. We'll sometimes do that in combination while they're already getting ruxolitinib as well. Um, but So I think it's reasonable to do that. You may want to consider, concurrent toxicities and things like that, but we found that combination to potentially be a good option in those lower GI cases.
Yeah, I think I sort of mentioned this too, that it's really hard to sit on these patients who are really sick with lower GI GVHD. And if they're not having specific toxicities, so we do sometimes add additional agents to Rux as long as there's not, again, overlapping toxicities and they're tolerating it. Maybe one more to choose. Is organ involvement the most important factor when sequencing treatment? I think we kind of touched on that a little bit. And
Yeah, I mean, it's definitely a consideration. The one thing I would say about the organ involvement piece is I think one thing I've heard from others and I hold true is that we have a number of agents. We have we know what their mechanisms of action are, but I think we also have to acknowledge that they may be hitting other targets that we're not aware of. And we shouldn't silo kind of thinking, oh, these patients or these agents only address fibrosis and these don't. Recently we published data with ruxolitinib, which people don't typically think of as having anti-fibrotic manifest activity. We published data that we do see responses in lung GVHD. There was another trial that talked about responses in sclerotic skin GVHD, and I think that we just have to keep an open mind. But that, again, doesn't help us maybe select which agent to use. And I don't think it's wrong to say I want to use either belumosel or axatilimab in a patient with fibrosis or fibrotic type organ manifestations. But I think we just have to acknowledge that it's a choice and maybe the data supports it, but it's not as definitive as our brains probably want to make it.
I think we're out of time, but Zach and I will be available if any other questions are you'd like to ask. So thank you.
All right. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by educational grants from Incyte Corporation, Mallinckrodt Pharmaceuticals, and Mesoblast Inc. To access all materials for this activity, visit peerview.com/XRT860.